Hello, everybody. Happy Thursday, the favorite time of the day, 7 p.m. Eastern Standard Time. I am here representing Life and Breath Foundation with an amazing speaker who will talk to us about general approach to sarcoidosis treatment and a little bit about Life and Breath Foundation. We are a nonprofit foundation based in Maryland. Our fearless leader, Sean Hall, started this foundation when his mother unfortunately passed away very suddenly from sarcoidosis, and family didn't really know about sarcoidosis. So Sean had recognized that this disease needed a lot of support, a lot of information. And so he created Life and Breath Foundation, and I am a proud board member of it. Next slide, please. Just briefly, I want to tell you that our values and our mission and our goals are to truly provide sarcoidosis community. And it's not just patients suffering with sarcoidosis, but also their caregivers, family members, and anybody who are interested in sarcoidosis. We want to provide effective tools that will be able to track their journey and help their quality of life. We also strive to provide nurturing environment for everybody who is affected by sarcoidosis so they can share their experience with us. And lastly, we want to build more awareness between medical community about sarcoidosis to really help to combat this chronic disease. And today, we have the pleasure and truly privilege of speaking to Dr. Adam Morgenthau, who is just a sarcoidosis Hall of Famer in my eyes, because he's not only that he's a director of Sarcoidosis Program at Mount Sinai, he also leads a very large support group for sarcoidosis. 95% of his patients have sarcoidosis. So you can't find anybody that has more experience, in my mind, and more passion and knowledge of sarcoidosis than Dr. Morgenthau. He's also associate editor of very prestigious journal named Lungs and a review of several pulmonary medicine journals. As somebody who published, I can tell you that it is very difficult and very prestigious to be an editor and also to be asked to review certain articles in journals. So it's fantastic. He is also member of Scientific Advisory Board of Foundation for Sarcoidosis Research. And I can talk more, but I'll let you read the slides. But what blew me away and what's maybe one of the most fascinating things about that Dr. Morgenthau is that he has helped to invent a drug that's called Kayacta TM that is going through trials right now and hopefully will be available for patients with sarcoidosis next year. So talking about a treat and real pleasure in having such a amazing doctor with so much passion about sarcoidosis to come and help our patients and their caregivers to get more information. And before I'm going to give microphone to Dr. Morgenthau, I asked him what made him interested in sarcoidosis, because usually, there's interesting stories about, what made people kind of go into their specialties. And he said that he became very interested in sarcoidosis in residency and then fellowship because this is, a very unknown disease with a lot of questions. And it affects truly pretty much the whole body in so many different ways. And he likes to be very patient-centric and see things as a big picture versus just focusing on a body parts. And so I thought this was really fascinating and again, very refreshing to have a doctor who truly understands that this is a whole person and not just a specific disease. So Dr. Morgenthau, thank you again for being here. And I'm going to pass the baton to you, and we can't wait to hear you speak. And I just want to say a lot of questions came in already. Oh, and Dr. Morgenthau, one of the questions, there was not a question, was from your patient who you saw in 2014. And the patient says, thank you, you saw me in 2014. You gave me very, very thorough exam, 6-page report. You did not rush me. So I just thought how amazing that you're getting positive feedback about your patients that you saw so many years ago and still they remember you. So anyway, thank you very much. And we are honored to have you.
Thank you, Irina. I really appreciate it. It was a glowing recommendation, and hopefully I live up to all of the things that you have said about me today. But anyway, I just want to, speak with everybody about how I sort of approach sarcoidosis and what I tell my patients. I think the information is broad and would be useful to any patient with sarcoidosis or some of their caregivers who may be listening. Just as an aside, I have no conflicts of interest with respect to the content of the lecture that I'm going to be delivering today. So this is an introductory slide, and really it helps to sort of outline what I'm going to talk about today. The basic approach that I use is sort of to ask a series of questions. The first question is the diagnosis of sarcoidosis correct? I then go on to ask which organs are involved, which organs warrant treatment, and what medication should be administered and how should they be administered. After all of that, I think it's important to determine whether the patient is responding to treatment. And then at the end, what can be done for the patient who does not respond to treatment? Now, all of these questions are very basic, but really when you get into the nitty-gritty, it's the details that sort of count. So let's start with diagnosis of sarcoidosis. Many of you are familiar with the diagnosis of sarcoidosis, but I just wanted to do a brief overview so we're all on the same page. In order to make the diagnosis of sarcoidosis, you need to have symptoms, physical exam findings that are consistent with sarcoidosis. This picture here is a patient with lupus pernio, which is a characteristic rash, usually around the nose, around the cheeks. It's almost diagnostic for sarcoidosis. So if you see something like this, this supports the diagnosis of sarcoidosis. But it doesn't have to come in the form of skin disease. Patients can have eye problems. As many of you know, you can have uveitis. This is a person with anterior uveitis. And, their manifestations of disease can come in this format. In addition to having symptoms and physical exam findings that are consistent with sarcoidosis, you need to have supporting data that is consistent with sarcoidosis. And supporting data can come in all different forms. Classically, it comes in the form of an X-ray. If you guys can see this picture here, this is what we call a stage 1 X-ray, patient with bilateral hilar adenopathy, which basically means that the lymph nodes in the chest are swollen, and you can see the arrows pointing to those swollen lymph nodes. This is very characteristic of sarcoidosis, and when you see this, it supports the diagnosis. But once again, even if you have symptoms and physical findings and you have a chest X-ray that is supportive of the diagnosis, in most cases, this is not enough to diagnose sarcoidosis. In most cases of sarcoidosis, you need a biopsy. And a biopsy of an organ that shows these collection of immune cells called granulomas. And granulomas are really sort of the immune system response to an unknown foreign substance or substances. In addition to having symptoms and physical findings, supporting data, and a biopsy that shows granulomas, sarcoidosis remains what we call a diagnosis of exclusion, meaning that we have to make sure that all of these findings, and in particular the granulomas that we see, are not because of anything else other than sarcoidosis. And we say not because we say other than sarcoidosis, what we mean is there isn't a cause. We don't know why the granulomas are there. But there are many different reasons people get granulomas, from bacteria to fungus to foreign bodies in the skin. All of these things can cause granulomas, and we have to do our due diligence to make sure that none of those things are causing the granulomas that we see. As many of you know, sarcoidosis can basically affect any organ, but it more commonly affects certain organs. And this is a chart that sort of gives you an overview of the organs that can be affected in sarcoidosis and the frequency at which those organs are affected. And you can see that the lungs, for example, are involved in 95% of cases. The skin is involved in approximately 20 or 25% of cases. Patients have lymph node involvement in about 15% of cases, and we can go through all of the rest, but you get the idea that we need to determine when we're assessing the sarcoidosis patient, we need to determine which organs are involved. It's really, really important to emphasize and focus on this slide because it's important. You know, organ involvement is not the same as organ activity. And just because an organ is involved doesn't necessarily mean that it needs to be treated. An organ involved means that there's evidence of sarcoidosis in the organ. And there's a difference between involvement of an organ and active disease within an organ. Active disease is defined by inflammation from granulomas, which impairs the function of the organ. And in some cases, active disease is also defined by poor quality of life, which we measure by quality of life questionnaires. So just to step back from the lecture that I've given so far, the first thing that we always want to do is make sure that the diagnosis is correct. And there is a rigorous process that we need to go through in order to be sure that the diagnosis is correct. We don't want to label somebody as having sarcoidosis when they don't. That's the first step. Once we are comfortable with the diagnosis, we need to define which organs are involved. And that just means that for a variety of different tests, we see evidence of sarcoidosis in a variety of organs. Once again, just because we see the sarcoidosis in these organs doesn't necessarily mean that treatment is indicated. Treatment is only indicated when there is activity or inflammation in the organ that impairs the function of the organ. It makes sense that we can define organ dysfunction or malfunction, however you want to call it, malfunction, dysfunction of an organ differently depending on the organ that we're looking at. So if, for example, we look at the organ system here in this list, we look at sinuses and we say, are the sinuses involved? Okay, maybe they are. We have a CAT scan of the sinuses that shows that, you know, there's some swelling in the sinuses, there's congestion, there's sinusitis, but we really want to know, does this patient need to have those sinuses treated? And the way that we know that is, one, by the patient's symptoms. Are they complaining of congestion, crusting, nosebleeds? And do they have an abnormal exam? And that exam is generally done by an ear, nose, and throat doctor who may or may not order a CT scan of the sinuses. So that's sort of how we assess the sinuses. How do we assess the eyes? Of course, patients have to have symptoms: blurred vision, light sensitivity, painful red eyes. They also need to be evaluated by an ophthalmologist. And the ophthalmologist exam, a slit light exam, is absolutely critical in determining whether somebody has inflammation in their eyes that needs to be treated. Ancillary testing such as CAT scans and MRIs may also be needed, but the bulk of examination by the ophthalmologist is really key. The heart is a very important organ that we need to assess. Of course, patients with cardiac sarcoidosis may have symptoms of chest pain, palpitations, lightheadedness, fainting. And we want to assess that organ by an electrocardiogram, a Holter monitor, perhaps an echo, but most importantly are two really important advanced cardiac imaging tests known as cardiac MRI and PET scan. These tests are sort of the gold standard for diagnosis of cardiac sarcoidosis. Most of you are familiar with evaluation of the lungs. Patients with activity in the lungs may have shortness of breath, cough, wheeze, and most importantly, they may have abnormal pulmonary function tests. Yes, they also may have abnormal imaging, but in my experience and in my opinion, the imaging is the least important of all of these things. The symptoms of the patient and the pulmonary function tests are much more important in telling us whether the lungs are not working properly and whether they need to be treated. The liver, we can look at blood tests. We can also look at imaging tests to assess. Same is true of the spleen. When it comes to neurologic sarcoidosis, symptoms are a must. Patients must also have an abnormal physical exam, and all of the symptoms and the abnormal physical exam are supported by imaging The gold standard, again, is MRI of the brain or spine. Many of you might have suffered from high calcium levels in the blood. It's very easy to assess calcium levels in the blood with a simple blood test. Of course, we must determine that the high calcium in the blood is because of sarcoidosis and not because of other reasons. But that is the measurement by which we use to determine whether treatment is indicated. Patients may or may not have symptoms depending on the level of the calcium in the blood and the rapidity at which the high calcium level occurred. So medications. Once we decide that a patient needs treatment, we then have to think about the medications in our arsenal, and we have to think about their side effects. And as many of you know, one particular drug is not effective for all patients, nor should it be given to all patients. Everybody is different. First of all, sarcoidosis patients have many different manifestations of disease. And we know from experience that, and for reasons that we don't really understand, that certain medications work better for certain manifestations of sarcoidosis. But also as important is many patients, in addition to having sarcoid, they have other medical problems. And for example, patients might have diabetes, and we don't want to give patients with diabetes steroids like prednisone. Many of you are very familiar with the side effects of prednisone. Prednisone can cause insomnia, it can cause heartburn, sweating, acne, increased blood pressure, increased blood sugar, fluid retention, weight gain, palpitations, mood changes, thinning of the bones, glaucoma. Some of these are present in some patients have all of these, some patients only have some of these. Some of these side effects develop only, really quickly after starting prednisone, and others take a long time to develop. It's really important to emphasize that the majority of the side effects of prednisone are associated with the dose. So the higher the dose, the worse the side effects. Azathioprine or Imuran is another drug that you may be familiar with, causing fatigue, malaise, abnormal blood work such as liver function and blood counts. Methotrexate also can cause abnormal blood work. Sometimes the day that someone takes methotrexate or the day after, they can develop joint pain, nausea, flu-like symptoms. Mycophenolate's another drug that we use. It's also known as Cellcept. It can cause nausea, headache, diarrhea, and stomach upset. Those are the big ones. Can also affect the blood work, but not nearly as often as methotrexate and azathioprine. Plaquenil is a very effective drug for certain types of sarcoidosis. It can cause nausea, diarrhea, dizziness, headache, altered mood. And the one side effect that we always warn patients about is damage to the retina. That is a long-term side effect of hydroxychloroquine, never happens early after treatment, and patients need to be followed by an ophthalmologist. And then finally, there's infliximab or Remicade, which is one of our relatively newer drugs that also has side effects such as headache, nausea, sinus congestion. It suppresses your immune system like many of these drugs and can increase your risk for infections like tuberculosis. So when I approach treatment and when I discuss treatment with patients, I sort of talk about treatment from a strategic point of view. This is a complex slide, so you'll have to bear with me for a few minutes just to go through all of this. But I think it's important to sort of give you a sense about how I think about treatment and how I share treatment with my patients. So you can see that one of we refer to this as a graph with different axes, and the axis going up and down is known as the y-axis. The axis going right and left is the x-axis, and then this arrow that's pointing towards the organ systems is known as the z-axis. And anyway, you can look at the y-axis here going up and down, and on the top part of the axis is inflammation, and on the opposite side of that axis is anti-inflammatory therapy. So a patient has a certain amount of inflammation in their system. We treat them with drugs to knock down that inflammation. If we're right at baseline here, then we're in the middle and we've countered the inflammation that a patient has. On the other hand, if there's too much inflammation in the system and there's not enough drug or not enough anti-inflammatory therapy, then patients may have progressive inflammation and worsening symptoms and disease. On the x-axis here is time. And you can understand that we treat people for a certain amount of time. And as time goes on, we get certain manifestations. Sometimes when inflammation is untreated for a long period of time, it can result in scarring. So I'm going to try and move through this. I've made a lot of the comments that I'm going to make going forward, but I'll just repeat them because it's a lot to take in all at once. So we know that the location of the inflammation and the extent of inflammation sort of determine what the patient manifests in terms of sarcoids. So if patients have inflammation in their lung, then they're going to have lung symptoms such as cough, shortness of breath, and wheeze. If that inflammation is weak, then the symptoms might be weak and might not cause too many problems, or might not cause problems for a significant period of time. On the other hand, if that inflammation is robust, then patients may have significant symptoms and, more importantly, significant decline in their pulmonary function. Why do we treat patients with sarcoidosis? We treat patients with sarcoidosis because we want to suppress the inflammation. Why do we want to suppress the inflammation? Because we know from past observation that when inflammation goes on and it's untreated for a long period of time, it results in scarring of the organ. And we know that scarring of the organ is really a permanent manifestation of organ dysfunction. And once scarring sets in, we really don't have any great drugs to reverse or minimize scarring. So we want to do our best to treat the inflammation as early as we can to prevent the scarring from happening. I alluded to this before, but really in every patient, for every organ system that we treat, there's a threshold level of drug that we give for patients. If we give too little drug, then the inflammation progresses. If we give too much drug, then we definitely suppress the inflammation, but patients have unneeded side effects, particularly when it comes to prednisone. Remember, the side effects of prednisone are dependent on the dose. So if we give more prednisone than a patient needs, they're going to have side effects that they otherwise wouldn't have. So we have to be careful about how much prednisone we give, and we need to be diligent in trying to find this optimal dose. So when do we think about using all of the medications that I talked to you about? When's it appropriate to use prednisone as opposed to azathioprine, methotrexate, Plaquenil? How do we know? Well, the most important thing to consider in all of this is this concept of steroid sparing. It can be a little challenging to explain sometimes, but I'll do the best that I can. Let's say that we have a patient who has pulmonary sarcoidosis, and we put the patient on 20 milligrams of prednisone, and the patient's symptoms of cough, shortness of breath go away, and the pulmonary function test either stop declining or they improve from where they were previously. And I'll talk about those differences in a few minutes. And then let's say after a couple of months, we decide that we're going to taper that dose of prednisone from 20 milligrams to 15 milligrams. And when we go to 15 milligrams of prednisone, the patient develops a resumption of symptoms and the pulmonary function tests decline again. We go back up to 20 milligrams of prednisone and everything disappears. What does that information tell us? That information tells us that the patient needs 20 milligrams of prednisone to keep their pulmonary symptoms in check and keep their pulmonary function from declining. Now, nobody wants to be on 20 milligrams of prednisone for a year or 2 years. Let's just say we're treating the patient for pulmonary sarcoidosis for a year or two. Nobody can stay on 20 milligrams for 2 years or even a year or two. So we've determined that we need 20 milligrams of prednisone, but we know patients can't tolerate 20 milligrams of prednisone for a year. The side effect burden will be too great. So this is when we think and we say, well, we need another drug. And we need a drug to lower the dose of the prednisone and keep the inflammation at bay. Why do we want to lower the dose of prednisone? Because even if we lower the dose of prednisone from 20 milligrams to 10 milligrams by introducing another drug, we've spared the patient significant side effects. This is the concept of steroid sparing. We add additional medications to spare the amount of prednisone that we need to give if we're just giving prednisone alone. So these are treatment scales that I just sort of devised just to sort of hammer home the concept. If you look at the scale all the way on the left, the prednisone is up and the inflammation is down. This is basically telling us that the inflammation is too heavy. In other words, there's a lot of inflammation and it's not adequately being treated, and we need to give more drug to suppress the inflammation. If we go all the way to the right, it's the opposite. We have anti-inflammation that's too heavy, meaning that we have a lot of prednisone on board. We're suppressing the inflammation associated with the sarcoidosis granulomas quite well, but we're really giving the patient a little more drug than we actually need, which means that we're giving them more side effects than they need. So we want to give a little less drug to keep the inflammation in check and reduce the side effects. And then the middle scale here means that the inflammation and the anti-inflammation, otherwise known as the prednisone, are equal and in check. And this is the balance that we really want to achieve. Now, I used prednisone here as a example of the anti-inflammatory medication, but you can think of this in terms of any anti-inflammatory medication. We want to have the right balance between suppressing the inflammation, but not having too much suppression of the inflammation such that we have unneeded side effects. So how do we determine whether the patient is responding to treatment? Well, I think the first thing that's really important to emphasize here is that the word response can mean different things to different people, and they may often be interpreted differently by the patient and the doctor. So the patient and the doctor have to be on the same page. In some patients, a treatment response means that the symptoms improve and the testing improve. But in other patients, this is not the case. Patients have had sarcoidosis for a long time. The damage from the sarcoidosis and inflammation has been done, and there are permanent deficits, and those deficits are not reversible. In these cases, treatment is indicated not to make symptoms necessarily better, or not to necessarily make the pulmonary function test better, but to prevent further decline. Now, treatment with anti-inflammatory therapy may have an effect on symptoms, but it's not going to reverse the symptoms completely. And if the patient has an expectation that the symptoms are going to completely go away and the breathing tests are going to suddenly improve when they've been abnormal and bad for many, many years, that's an unrealistic expectation of the patient. So this discussion has to take place between the doctor and the patient. What are we trying to achieve? So what happens when the patient doesn't respond to treatment? Well, when the patient doesn't respond, we do everything we can to modify those things that we can modify. Supportive therapies like oxygen, pulmonary rehabilitation. If people have holes in their lungs that collect phlegm, we try and do clearance measures to get rid of that phlegm. If they have high blood pressure in the lungs, such as pulmonary hypertension, which is a consequence of the sarcoidosis, then we try and treat the pulmonary hypertension. Pulmonary hypertension does not respond to medications like steroids, methotrexate, azathioprine. And if all of that still doesn't do the trick, then we have to talk about transplant. And we always want to refer patients to transplant earlier rather than later, not when they're sick and, falling off the cliff. We want to refer them before they fall off the cliff, so an evaluation can take place and transplant physicians can look at the patient and assess the patient for whether that patient is a good candidate for transplant. So I hope that, the information that I provided to everybody today was useful. It's a lot of information, a very short period of time, brought up a lot of different issues, and now I'm happy to answer questions.
Dr. Morgenthau, first of all, thank you so much. This was fantastic. The steroid sparing explanation was probably best that I've heard. So I'm sure that our patients found it very helpful. We have a lot of questions, and let me start with, there were a lot, but I'm going to sum it up in kind of one question where people are asking, first of all, how do you know when inflammation is, let's say, normal or low? And how do people measure the treatment, if treatment is working? Is it by scans or really by how they feel?
Yeah, it's a combination of things, and it really depends on the organ that we're talking about. So let's take the simplest organ. The simplest organ is the lung. How do we know if a patient is, getting better or responding to treatment? Again, we have to first start out by saying, what are we looking for? Are we looking for improvement? Or are we looking to prevent further decline? So if we take the first scenario, improvement, first of all, we want to see that the patient's symptoms are getting better. So if the patient comes to the doctor, and they have cough, shortness of breath, and wheeze, and we treat them with, let's just say, prednisone, we want to see that the bulk of those symptoms improve. Now, they may not completely go away, or they might not, or some may go away and the others may not, but we want to see improvement. We also want to see improvement in pulmonary function testing. That's really important because the pulmonary function tests tell us how the lungs work. The imaging tells us how the lungs look. And when it comes to sarcoidosis, it's better to function well than look good. So we want the imaging to improve. But if the imaging doesn't improve as much as the pulmonary function test, that's okay. So in this particular situation, we're assessing the patient via symptoms, via pulmonary function tests, and imaging. Those are really the three things. And we look for improvement in all three, but sort of cut some slack to the imaging because the imaging is not as important in determining the patient's overall condition. Now, when it comes to the patient who, has already had a lot of damage, their PFTs have been abnormal for quite some time, and they have abnormal imaging and some symptoms of, again, cough, shortness of breath, and wheeze. And they come to you and all of a sudden they're starting to decline again. They've been bad for a while, but they've noticed more recently that they're even worse. Then the goal of treatment becomes to not allow further decline. So we're never going to get back to the point where the patient just started with their sarcoidosis. But what we want to do is sort of keep them at their current baseline. We want to prevent them from worsening, and we want to see that the symptoms don't worsen. Perhaps we can make them better with other therapies or other things, but at most, we don't want them to worsen. The same is true of the pulmonary function tests. We want to prevent them from declining. And then when it comes to the imaging, it's all over the map. Sometimes the imaging will worsen and the patient will not. And sometimes the imaging will stay the same and the patient will worsen. Ideally, we would like to keep the imaging unchanged as well.
Interesting, because the last question, and Dr. Morgenthau, can I ask you to stop sharing so people can see you better?
Oh, yeah, sure.
Thank you. The last question is kind of similar. I just want to piggyback on it. So the person, and I just want to say, guys, just again, that Dr. Morgenthau is giving us a general lecture. None of it should be taken as a medical advice, and he's not treating you as a doctor. So even though I'm going to talk about a specific case, he's going to give you a general idea. But if patient was diagnosed last year and then was on prednisone 20 milligrams for 1 year, and just saw a doctor who started her on methotrexate and decreased prednisone from 20 to 15, that person's last imaging was in December, so almost a year ago. So they're asking, should they request another imaging since the medication changed?
Yeah, I mean, it depends on a lot of different factors. Methotrexate, many of you know, methotrexate can, in relatively rare cases, cause scarring of the lungs. So anytime I put somebody on methotrexate, I try and get an X-ray beforehand and then an X-ray sometime during the course, just to make sure that nothing is developing. But again, I hearken back to what I said before. The most important way to assess whether you're improving or not is your breathing tests and your symptoms. So if your breathing tests are newly bad and you go on therapy, then you want to expect that there might be some improvement. If your breathing tests have been bad for a really long period of time, then you want to expect that there might not be decline. So it's really how you're feeling and what your breathing tests show. The imaging is sort of less important.
Mm-hmm. Wonderful, thank you. There were quite a few questions about vaccines and medications. So I don't want to ask kind of every question, but let me sum it up. So first question is, if patient is taking prednisone and methotrexate while getting COVID vaccine, do you think it's just as effective, or should they worry about maybe vaccine not being so effective?
Yeah, so we don't have all the data in sarcoidosis patients specifically, but we have data in other patients who are taking these medications. And the data suggests that, these drugs do blunt the antibody response. Remember, when we give a COVID vaccine, we want antibodies in the system to develop. So if we were to develop COVID, our immune system would be primed to fight off the infection. And all of the studies have shown that patients who are on these types of agents have less of an antibody response than those who are not on these agents. They've also shown that there are differences depending on the medications that you take. So the reduction is an antibody generation is different for somebody who's just taking methotrexate as opposed to somebody who's taking methotrexate and prednisone. Generally speaking, when it comes to methotrexate, what I generally do based on previous literature that was associated with pneumococcal vaccines in the presence of methotrexate is I tend to hold the methotrexate for 2 weeks prior to the vaccination. And that's supported by prior literature that suggests that when you hold the methotrexate 2 weeks prior to pneumonia vaccine, you get better pneumonia vaccine responses. So I do the same thing with COVID. With prednisone, you can't really stop the prednisone abruptly. That's dangerous. So we have to leave patients on prednisone and give the vaccine. It's clear that your antibody responses will be reduced compared to somebody who's not on these medications if you're taking these medications. That being said, it's not clear that you will have no antibody responses. It depends on the patient, it depends on the drug. So don't think that you're absolutely not protected because you're taking these medications. I tell my patients to be extremely careful and not act as though they are vaccinated in every situation. So, outdoors is one thing, but indoors is quite another.
Interesting. Thank you. There were quite a few questions about COVID in general, and if person with sarcoid gets COVID, if you have any idea on the appropriate medications. And I think this is just 2 patients specific to answer on this webinar, unless maybe there's some sort of general.
Yeah, I think there's a lot of debate about whether sarcoid predisposes people with sarcoidosis to a worse outcome. There's some literature that suggests yes, there's other literature that suggests no. There's other literature that says it depends on the patient and the comorbidities, the comorbid illnesses that a patient has in addition to their sarcoidosis. I don't think we really know the answer to that yet. I think, sarcoidosis patients who get COVID should be treated like any other patient. They may be eligible for the monoclonal antibody, although I just read something today that said that the monoclonal antibody cocktail may not be as effective in Delta as it was in other strains of COVID. That being said, when patients come into the hospital and they require oxygen, we generally give them steroids if they're not already on steroids. Steroids are not going to hurt sarcoidosis patients. We know that. But if you're a sarcoid patient with diabetes or some other, manifestation, then, you have to be careful about the steroids. So it's really hard to answer, without knowing the specifics of the patient.
Yeah, I thought so, but I figured just in case I'll ask. There were some questions, and we get them all the time, and I would love to hear your take on it, because we had few doctors on who are really more of a functional medicine physicians, so very much about the anti-inflammatory diet and other lifestyle. And so questions that always come their way is about vitamin D. How much is too much vitamin D for a patient with sarcoidosis? And also, if you had a success with your patients who maybe changed to anti-inflammatory diets, have they gotten better? And if yes, what diet do you personally recommend?
So I just gave a talk to our support group on, diet for patients with sarcoidosis. And I have to say that there's very little literature out there. And all of the literature it's not like randomized controlled trials or any of those things. The data is poor. I think so that's one thing, and I'll get back to that in a second. The other thing is I have patients anecdotally who tell me that, they stopped eating meats, or they cut down on their sugar, or they, got rid of gluten. And, some of these patients feel better, and others, there's no difference. I think there is some, literature to support having an anti-inflammatory diet in sarcoidosis, but the literature is far from robust. And I don't think that there's enough out there yet for me to say definitively every sarcoidosis patient should be on an anti-inflammatory diet. That being said, there is also not a lot of evidence that suggests that it will hurt you. So unless you have a specific, reason that you can't have certain anti-inflammatory foods, I generally tell my patients if they want to try it, it probably won't hurt, but it may not help. Mm-hmm. Vitamin D is a super complicated issue in sarcoidosis because there are so many different, variables to consider. So where to start? So there are some patients who have problems with vitamin D. In other words, we call it dysregulated calcium metabolism in sarcoidosis, and they make too much vitamin D because of their granulomas, and that vitamin D leads to high calcium in the blood or high calcium in the urine. High calcium in the blood, probably in about 10% of all patients. High calcium in the urine, probably about 15% of all patients. And these are patients who are not taking vitamin D, eating too much vitamin D, or going in the sun too much. These are just patients with sarcoidosis who have a problem with their vitamin D. So this is one group of patients. Another group of patients are patients who have sarcoidosis. They don't have a problem with their vitamin D, but when they're given vitamin D, they develop a problem. And that's a different set of patients. The thing that's really important to realize is if you select 100 patients with sarcoidosis and you draw blood work on them, and 90% of them are going to have what's called a low 25-OH vitamin D, which is the level that's used to measure vitamin D deficiency. But as we may or may not know in sarcoidosis, there's another vitamin D level that's really important, and that vitamin D level is made by the granulomas. It's an active form of vitamin D. And that one is called the 125. And that one is normal or elevated in 90% or so of sarcoidosis patients. So we really have to be careful about giving patients vitamin D. And it all depends on whether the patient has problems with their vitamin D from the outset when their sarcoidosis is diagnosed, when they have problems with their vitamin D only if they're given vitamin D. And then it also depends whether they're on medications, because some patients may be given vitamin D and develop a problem with their calcium. But if they're on a medication like prednisone or methotrexate, they may not know, because the prednisone and the methotrexate is actually treating the vitamin D problem. So this is a really complicated subject that I sort of individualize towards, my patients, and it's very hard to make a general recommendation. I would say if you're known to have a calcium and vitamin D problem, you really have to be careful about how much vitamin D you take. There are other patients who have had sarcoid for years and they've never had a calcium and vitamin D problem, but their vitamin D is low. And, those patients can be given vitamin D without any sort of issue. So it's very hard to generalize.
Yeah. And that's what we hear, but I figure maybe. Another very interesting question. I know the answer, but I'm not going to say it. I'm going to test myself. But person is asking, have you seen an uptake in sarcoidosis from last year or within last year?
Well, so there's a lot written about this, that sarcoidosis is more prevalent than it used to be. I don't know if that's the case. I think that, some people do think that's the case. I think we're better at recognizing sarcoidosis. We're better at diagnosing sarcoidosis than we used to be. So I think there is more sarcoidosis, but whether there's truly more sarcoidosis or we're just identifying sarcoidosis better, I don't know. That's what I would say.
That's interesting, because I thought because of COVID and maybe people being in quarantine, maybe it went down since people were not getting, to their doctors. But yeah. I guess you're saying that literature says that there's actually uptick. So it's interesting. Okay. Super interesting questions. I have no idea what the answer is, but there is a blood shortage in the area where this patient lives. And they're asking, is it okay for sarcoidosis patient to give or donate blood?
Yeah, so we always say it's okay, but there are certain organizations who have different policies. And most of the time I found that they don't want sarcoidosis patients to give blood. But there's no reason that we can think of that sarcoidosis patients should not be able to give blood.
Perfect. So CND, I guess, find out Red Cross or wherever you're going to donate the blood if they're okay with sarcoidosis. But Dr. Morgenthau is okay with that. And another super interesting question. Patient had 2 PET scans this year, and she's asking, she's due for mammography and colonoscopy this year. So she's asking, because of 2 PET scan, can she wait another year or should she actually get them done?
Those are totally different modalities of assessing, breast, possible breast disease, breast cancer, precancerous breast lesions. I think that she should speak with the doctor who's asking her to get the mammography to confirm. But my feeling would be she should probably get the mammography because these other modalities don't look at the breast in the same way.
Wonderful. We had a lot of questions about medications, which I feel like you've answered very thoroughly. Side effects of corticosteroids. A question that came up is, somebody's asking if you think sarcoidosis can run in family. Is it?
Yeah, it can run in families. There's lots of literature on this. It doesn't always run in families, and just because it runs in families doesn't mean that every family member is affected, but there is a genetic predisposition to sarcoidosis. And if you have sarcoidosis, your first degree relative is at a 3 to 5 times higher risk of developing sarcoidosis compared to the normal population. That doesn't mean, however, that if you're a parent and you have sarcoidosis, that your kid is going to develop sarcoidosis. The disease doesn't work that way. And, we don't screen family members for sarcoidosis unless symptoms or, there are exam findings or imaging findings that, sort of suggest that sarcoid is a possibility.
Mm-hmm. Yeah. And one more question. There was actually quite a few questions about remission, and general gist is, what if some doctors say I'm in remission and the other one doesn't? Another question was more about, I've been in remission, but I'm afraid can sarcoidosis come back, which we know the answer. But I guess talk to us a little bit about remission and maybe what to look for and how do people actually know that they're truly in remission?
Yeah, so remission is a sticky subject because people use the term differently, and we don't have a strict definition of remission in sarcoidosis. I think the definition that I use and a lot of my colleagues use is free of disease, meaning free of symptoms, free of the need for medical therapy. for roughly a period of 3 years. So you have to be off of treatment, and you can't have symptoms attributable to sarcoidosis for roughly a 3-year period. Now, there's a lot of nuance in that, because again, if somebody's had sarcoidosis for many years and they have decline in their pulmonary function, but it levels out and it doesn't go any further, but there are permanent deficits, they're going to have continued symptoms. So they're still going to have symptoms from their sarcoidosis, but their pulmonary function test may have not declined for many years. They have no new symptoms, and they have nothing else that suggests that their disease is active. That person can be in remission, but that's very different than the person who starts up with sarcoidosis, doesn't require treatment, and then they get treated, their disease goes away, and they're free of disease for 3 years. The other controversy is there's not agreement among experts as to whether the chest X-ray or the chest imaging needs to normalize. So many patients with sarcoidosis can, I think, be in remission, but they'll always have a chest X-ray that's abnormal and tells us that they have sarcoidosis. So there's a lot of gray area to this, but you can't be in remission when you're on therapy. Let's put it that way, because the therapy is controlling your disease. So I think, was that an answer to all of the question, or was there another part? For whatever reason, I think I lost you, Irina.
I'm sorry, I'm talking away. I was muted. No, you answered it. Can low iron be contributed to sarcoidosis at all?
Not that I know of. There may be some literature. I'd have to look that up, but I don't think so. I mean, you can be anemic because of sarcoidosis, but I'm not aware of being anemic because of iron deficiency associated with sarcoidosis. Maybe if you have bone marrow sarcoidosis, you could be iron deficient. I honestly don't know. I've never heard of that.
I just want to commend you and say I love it when really amazing experts have humility to say I don't know, because a lot of times patients come to doctors and they expect that you know everything and everything, and you do know so much, but to say I don't know, it's just it's very heartwarming. And I just want to say, people are saying, I can't tell you enough how much people are saying how brilliant you are, how much they're blessed that you're giving this lecture.
They don't know me very well.
Doctor is so bright. I mean, it's just, I just want to make sure you feel the love that's coming from our patients and everybody that's on this webinar. There was one question asked about since a lot of the person saying, since a lot of diagnosis happen actually after emergency room visit, how can we I guess get emergency physicians to know better or more about sarcoidosis? And so I can say, just from our standpoint, Life and Breath Foundation, we're doing so much education to the medical community. I'm a nurse practitioner, and I can tell you that I think I've maybe we heard something about sarcoidosis in nursing school as a lung disease. It was probably that. And at the graduate school for nurse practitioner, it was a brush on maybe a paragraph or two. So, and I talked to, a lot of my friends who are, primary care physicians, they say the same, it's very quick. It's maybe, a little bit of one lecture, if that. And so we recognize the need for medical community, especially emergency rooms and primary care, probably best to learn more about sarcoidosis and really to give them tools. So we're working very hard with the GBMC in Maryland we are developing actual scholarships, Dr. Morgenthau, for residents who want to learn more about sarcoidosis. So we are doing the scholarships to pay for them to go to conferences and to present, and then to bring that back to medical community. So as the Life and Breath Foundation board member, I'm very proud of the work that we're doing, at least now locally, to spread that knowledge within medical community. So that's, Paul, I'm answering your question and not Dr. Morgenthau. Mm-hmm. But I just want to say that you are truly fantastic. You're so smart. I love the fact that you use patients a lot in your, even when you talked, and I'm very much patient-centric kind of provider. And sometimes, we get so busy that we don't think about the patient on the other side. It's mostly about, what the evidence say and, how can we help you faster? So the fact that you're always bringing patient back into the equation, that just speaks value of you as a doctor, as a person, as a professional. We are lucky to have you. I'm sure we're going to have a lot more questions probably coming our way, but we'll compile them and try to answer them. Maybe we'll email you. And we'd love to stay in touch and have you be more connected to Life and Breath. And our patients truly loved you. So thank you again for being with us.
You're welcome. Thanks for having me. Appreciate it.
Guys, have a great night and stay tuned for more webinars from us. Bye, everybody.
Bye.